Hello. I really want to thank everybody who's still hanging around. This has been a great event, and I'm Lennie Woods. I'm with the Clear Cell Sarcoma Foundation, and this is our last session. But thank you all for this great 3-day event. I really have enjoyed meeting a lot of you and hearing all the speakers. So for our final, we're going to talk about AYA cancers, young people getting cancer too. And first, we're going to hear from Dr. Brian Pennarola from NCI. He specializes in pain, palliative care, and peds oncology.
All right. Well, thank you very much for the introduction, and thanks everyone for the opportunity to speak today. Want to acknowledge first that I'm pinch hitting for Dr. Brigitte Widemann and Dr. Lori Weiner, who are both wonderful, incredibly accomplished people. Oh, good. Is everybody okay? As long as it's not a person. But thank you again. I'll explain this picture in a little bit, so this picture will come back up. But the title of my talk today is Adolescents and Young Adults, or AYAs, Living with Sarcoma. So what this talk will cover, this is just kind of outlining the objectives briefly. We'll first just try to set the stage a little bit to define the landscape of AYA sarcoma. We'll then talk through some specific challenges that patients battling sarcoma and their families navigate for this age range, and finally close with a couple slides about strength and resilience. So just some numbers, and these are a little bit, they're US centric. I do reference one global thing, but just for some of the numbers that I have are based on US numbers. About a third of the US population, so it's 112 million people, falls within the NCI defined, National Cancer Institute defined AYA age range of 15 to 39 years. Globally, it's actually slightly higher than that 33% average, but it's a lot of people. And in 2024, the approximate number of AYA cancers that were diagnosed in the United States was 84,000. That's about 4.2% of the total about 2 million cancer diagnoses that happen in this country. So the point that I'm making here, and I've heard the word rare many times in this room already, is that AYA cancer across the board is rare. But perhaps more importantly, I think and this will hopefully contextualize this talk, compared to other older adults, the experience of being an AYA with cancer, when you combine those two percentages, is even more rare, is extra rare. It's a third of the population, but they're only accounting for 4% of cancer. So being an AYA with cancer is a more isolating experience. This is way too tiny, and I just put it up because it's pretty, less to actually read through it. But this is also a little bit dated. This is a study from, I think, 2008. But that was just showing kind of that orange bar there is the AYA age range, and these are kind of all the different cancers that appear during that time with their relative rates. And the only thing I really wanted to highlight here is that 10% of AYA cancers are sarcomas. So that's combining the soft tissue sarcoma and the bone sarcoma boxes there. So this rarity aspect is even more true for AYAs with sarcomas. At the same time, though, another way of looking at not directly this data, but other data, is that 51% of certain types of sarcomas, non-Kaposi sarcomas, occur in AYAs. So while this is a really rare disease with a really relatively small number of people encountering it, the people that are encountering it are, this is most likely happening to this age group. So this experience of navigating a sarcoma is oftentimes put upon AYAs. So I think the reason why this talk hopefully is important. The formatting might get a little messed up, and this is my joke slide, so maybe the joke won't land, but we'll see. So the first question, what's so hard about being an AYA? As a 36-year-old myself, I do fall into the age range. I'm bordering on that elder millennial. But the other group that's in the AYA age range is Gen Z. So I just had one meme in here because that's sometimes the one thing that unites Gen Z and millennial senses of humor. And then getting back to the talk though, what's so hard about being an AYA with sarcoma? And this is where I brought this picture back up that I showed in the first slide. And what this is trying to show is that this age range of 15 to 39, 15 when you start high school, and when you blow out the candles on your 40th birthday cake, a lot of things happen in this phase of life. You are kind of building the person, you're building the life that you will then go out and fly into the world in, kind of in all different phases. And when you overlay having cancer, particularly a cancer as disruptive as sarcoma, onto that journey, it can evoke that analogy of trying to build a plane while you're flying through the air. And there are a variety of different factors that make this really challenging, that really bring this to light, what's so hard about being an AYA with sarcoma. So personal societal factors, I already kind of referenced this, but this is a period of life with a huge amount of flux and a huge amount of navigating different really important transitions. So going through higher education, getting your first real job, getting off of your family's cell phone plan, which I'm working on, just things like that. Having really serious relationships, having your own family, right? A lot of things happen in this phase of life. Complicating that even further is that in the medical system, there are also really, really true challenges that these patients encounter. Physical space is one. This is easy to visualize when you have a standalone children's hospital on this side of the street and an adult hospital on the other side of the street. And that standalone children's hospital doesn't let you in if you're over the age of 21 or you're over the age of 18 in some places. But it can also be a little bit more subtle in the sense that, even though there may be kind of AYAs that are accepted in different types of pediatric clinics or vice versa, kind of younger teenagers accepted in adult clinics, there is a sense of not being in the right place, perhaps, for AYAs of encountering that situation. The other kind of main thing, and I think this conference is against this idea, but is that the communities that AYA or that pediatric and adult providers and medical systems set up are also themselves naturally siloed. So I reference this in a little bit, but there's the Children's Oncology Group that does most things with pediatric cancer here in the US, and then a variety of different adult oncology groups that kind of create conversations, have conferences, have publications that they all themselves will read more and reference that may not crosstalk as much as they should. So this idea of siloing, that people are siloed. I really briefly just put this up with the reference here too, because I'm not going to cover this more in my presentation, but want to acknowledge too that there are also within this age range specific biologic factors that may make treating these sarcomas harder or perhaps just different, right? And that the harder aspect of it could just be that we've studied other things better. So what I'll do now is in the next kind of series of slides, I'll talk through some studies at a really kind of basic level. So this isn't going to be like a journal club where I go through the methods and critique the studies. This is more just showing some highlights to kind of try to illustrate this landscape a little bit better and go through these challenges a little bit more. So the first couple studies I'll talk about focus on this idea that AYAs with cancer, and especially sarcoma, experience high symptom burden. So this was a study done in Canada, looking at, this was just cancer across the board, but I will make one point about sarcoma at the end, but looked at about 500 adolescents and young adults diagnosed with cancer, and about 5,000 adults over the age of 40 diagnosed with cancer. And they looked at they talked about symptom burden at diagnosis and then at multiple points in time over the course of the first year, kind of after diagnosis, and found that while things were similar at baseline with regard to the experience of fatigue, well-being, anxiety, depression, pain, nausea, and poor appetite, 1 year later, the AYA patients were significantly more likely to have moderate or severe anxiety or depression, And at some point kind of along that timeline, we're also more likely to experience a higher amount of pain, fatigue, nausea, and poor well-being. And they didn't kind of talk about statistical significance in this particular sub-analysis, but when they looked at AYAs with sarcoma, of which there were 20, so that's even 20 of 500 is even less than the 10%. But the 20 patients with sarcoma that they had were more likely at all time points to have higher symptom burden compared to the other AYAs. This is a bit of an older study, but it was actually done here at the NCA by Dr. Lori Weiner, 2006. I was a junior in high school. And this study looked at survivors of pediatric sarcomas, kind of far in the future when they were themselves AYAs, and found that these patients were at a really high risk of persistent psychological distress. So what this study had done is it looked an average of 17 years after completion of treatment for a pediatric sarcoma, and found that 77% of those patients experienced persistent avoidant behaviors, intrusive thoughts, enduring worries about their health, and difficulty adjusting to employment and school. And that 12% of these patients, and again, this is 17 years on average after diagnosis, met diagnostic criteria for PTSD. Another important thing to talk about, and perhaps more importantly, is that AYAs with sarcoma may struggle with aspects of their identity as they navigate cancer and life. So in a study of, I think this was from 2023, of 176 AYAs who had survived cancer in Europe, they found that about a little more than a quarter of them had long-term impaired social functioning. And again, this is a little bit of a theme, but this is years beyond diagnosis. And in a multivariate model showed that things that made that social functioning even worse were their cancer forcing them to make lifestyle changes or changing their employment status. And then in this really interesting study out of the University of Wisconsin, I think it's McKay et al. In 2021, they first kind of framed this study with this idea that the National Comprehensive Cancer Network, NCCN, has quality guidelines that exist for care for AYA patients with cancer around specific critical discussions that they should be offered. And what this study did is it was relatively small numbers, but it looked at 43 AYA patients with sarcoma and looked at two kind of simple things. One, how often are these critical discussions being documented in the electronic medical record? And two, when you ask the providers that take care of these patients, how well do you perceive your AYA patients have been, had these things talked about with them, and compared those two things. So how often are they documented in the chart? How good basically are we doing at covering these topics? And what they found was that generally things were not well documented, but people thought that they were covered pretty well. So when you look at personal finance, for example, 21% of the time there was something in the chart about that, but 84% of the time providers felt like, yeah, I think we covered that pretty well. And similar patterns were seen with talking about fertility, genetic counseling, and clinical trials discussion. I did put this one here at the bottom, more just to spark curiosity, or this is the one that kind of had a different percentage. But when they asked about school and employment status, that was actually something that was documented pretty frequently. Maybe it was like, built into the note template, or but only 36% of providers actually thought that patients had good access to those resources. But just in generally, there's aspects of these identity challenges that we as providers may not address very well. I think this has been covered a little bit here before, and I'm sorry I wasn't here for the rest of this awesome conference. But I think it's well known that AYAs also struggle with access to clinical trials. This was first kind of really established about 20 years ago when they kind of compared clinical trial enrollment for this age range with outcomes. And while the curves in general survival rates were getting better for pediatric and older adult populations, that survival improvement for this age range is not as good. It's a much flatter growth. And there's a variety of barriers that kind of explain this or contribute to explaining this. So one, there are just fewer trials for this age range. This is something, again, that's been improving over the last 20 years, but still relatively fewer trials. And one of the reasons for that is the idea of strict eligibility. I mentioned, the idea of a freestanding versus adult hospital, and sometimes that can bleed into kind of who you decide is eligible for your particular clinical trial. And then I've already referenced this too, but poor communication between these two silos of care. This patient level knowledge, I kind of take issue with, because to me, patients having insufficient knowledge about something is probably our fault and not a patient level fault. But I do think these other two topics are really important to think about. And that's when you imagine what it takes to go through a clinical trial, perhaps traveling a far distance, perhaps enduring a treatment that we don't really know what the side effects are going to be, or how bad they're going to be. To ask someone in this critical building their plane phase of life to sign up to endure that when they're starting their family or doing whatever, that may be a really huge decision to try to make. So these financial daily life concerns, quality of life concerns, that is a barrier that is really important to think about. I'll reference this, I'll talk through this on the next slide a little bit, but this, again, 20 years ago that this was first highlighted, there's been progress in that time. And one of the main things, at least here in the US, is the establishment of the, the establishment of the NCI National Clinical Trials Network structure. If somebody wanted to kind of torture me with asking to go through these acronyms, I might be able to do it from memory. But basically the main points here are that the COG one is the pediatric one, and all the other ones are the adult world ones. And the idea behind this NCTN is to centralize certain functions to basically make it easier for there to be good crosstalk about clinical trials. And actually within this group, there is a NCTN SARC, where SARC stands for Sarcoma Alliance for Research Through Collaboration. AYA Clinical Trials Sarcoma Working Group. So kind of right down the alley for this audience, that was established in 2019, that is actively working to try to kind of bring this structure to an approach to clinical trials for AYAs with sarcoma. And another thing that I think is important to acknowledge, and is a way to kind of also improve access, is the idea of having specialized AYA cancer programs. And just, I'll talk through this a little bit on the next slide, but there are, I'm speaking to this global audience, I'm sure people know some of these things much better than I do, but there are different national initiatives, but here in the United States, there is not at least kind of a cohesive national initiative that's kind of coming from our government system, especially without universal health care. So the last two slides, I'll kind of frame things a little bit more positively, but it's really important to acknowledge that AYAs navigating sarcoma benefit from community. And I will only speak briefly about this, but I know that our other speakers have incredible perspective on this as well. But when we think about what goes into that AYA program, there's good guidance about what it should include. This includes, definitely a multidisciplinary team, so not just one doctor and one other person, but really a team of different professionals kind of working together to provide good care, so that we can hit all those really important conversations that NCCN acknowledged. So making sure that we're talking about fertility, genetic counseling, financial counseling, clinical trial education, and a lot of different elements of psychosocial support, and that all of this is also done with this idea of transitions being in mind. Those transitions from pediatric to adult, those transitions from cancer to survivorship as well. And perhaps most importantly, trying to address that idea of why this population was siloed in the first place. We need to try to have generally more flexibility in how we care for patients in this age range. So an example of that would be trying to avoid strict age requirements whenever we can. And then really importantly, and again, just knowing from the experiences of my other panelists here, we as as the community kind of coming up with these teams or these interventions, being really mindful and self-reflective and reflective with input from patients and families about how we can improve them to make sure that we're doing a good job. And this final slide, because I can speak a little bit just from reading the literature about some of these experiences, but don't want to take more time from my other panelists here, is this point that AYAs navigating sarcoma and their families are strong and resilient. And while I've commented mostly on generally negative things when talking through these other studies, there's actually a good body of literature as well that can prove this point, or that addresses this point. So I've included one here, but there are definitely more. But this one looked at qualitative interviews for 17 AYAs with cancer in general, 8 of whom had sarcoma. Initially, kind of about 60 days after their diagnosis, and then serially over time. And this was a qualitative study looking at like several hundred hours worth of interview recordings. And the main objective, the main thing that they commented on, was that they wanted to look at in the conversations, how much were like the benefits of this experience talked about versus the burdens of this experience talked about. And what they found was that like about 70% of the time, most interviews actually had a higher benefit to burden ratio, meaning that AYAs found more good than bad in their experience. And some of the examples that had come up, and again, this is a very rich qualitative study, so this is just briefly summarizing, were a change in self, so feeling personally stronger, developing new coping skills, having more authentic relationships, having a changed philosophy about life that they felt was positive, so that would include higher sense of meaning or increased altruism. So thank you for your time and your attention, and want to give Matt and Lennie definitely time to talk to, but open to any questions. I'll do my best.
Wow, thank you, Dr. Pennarola. I would really like a copy of that to take home and show my kids, but could you add in about the cell phone thing?
Sure.
That's the first step. So next we have Matt Shaw, who is a patient advocate, diagnosed himself at age 21, and he's doing some amazing things. I'll let him tell you all about that. Matt?
Awesome. Thanks, Brian, for the awesome presentation. Hi, everyone. My name is Matt Shaw. I'm a patient advocate from Vancouver, Canada with the BC Cancer Agency. I don't have any slides today, so I just have a couple stories to share with you, and hopefully you learn something new about the AYA experience. So my first story is kind of about this building a plane and while flying it story. And in 2021, I was in my 3rd year of university, studying human diseases. And soon after, I was diagnosed with myxoid liposarcoma. So I guess I didn't study hard enough. Yeah, so the reason I brought up this is that in the hospital, after I got a major surgery to remove the lump from my hip and get a skin graft, I was in the hospital for about a week recovering. And during that time, I had a lot of pressure still to keep up with school and not fall behind with university and work, what I wanted my career to be. Throughout this time, I've been applying to medical school multiple times, and in Canada, it's a very competitive system. So in not wanting to fall behind, and in the week that I spent recovering from my surgery, I had a job application deadline. Now looking back, it seemed quite foolish that I would apply for a job right after I had a major surgery. But in the time and in the moment, I felt like that was the most important thing for me to do. But I was so nauseous and I couldn't walk, and so I spent time in the hospital just laying in my bed, and I had to get my friend to come over, and he sat beside the bed with his laptop while I laid there with my eyes closed, quite nauseous, and I spoke out loud to him what I wanted my resume and cover letter updates to be. And so he penciled those in and he submitted it for me. And about a month or two later, I ended up getting the job. And so I'm glad that in the moment I was resilient, but it seems quite insane that I had to do that. And similar with all the other rigors of the medical school process, I kept up with a full course load and working part-time in research and volunteering and all the other aspects of life during my treatment and my recovery. And so that's my first story about the multiple things and ways that life pulls you while you have cancer at that age. The second story is about how I found my people in cancer advocacy and also in peer support. And I think the theme here for me is that peer support is so important, and it's important for us to know that we're not alone when it's such a rare diagnosis and a rare demographic. And I have a couple stories of who I met, and they're all these coincidences, but I think that fate kind of led me to these people. And so the first person I met with the same diagnosis as me was a mutual friend. And we actually went to the same university, and I don't think we would have found each other if my friend didn't go skiing and found out that they had the same diagnosis as me on the ski lift. And the friend thought like there was no way, myxoid liposarcoma, we haven't even heard it ourselves, but they happened to have the same diagnosis, and so we connected. And we chatted here and there online, but nothing really came from that. And later on, I went to a local cancer event together, and I met a couple other friends there, but again, nothing came from that. And later down the line, I found out that the friend had been in an online AYA support group. So I was added to that, and we had a couple Zoom calls. But of course, it's hard to find other patients that are young adults that also have sarcoma. And so in that group, it was AYAs, but they had all types of sarcoma, of cancers, some from childhood and some recently diagnosed. And I was just going through my diagnosis and treatment at that time. And so it was really valuable for me to be in a Zoom room with these people that shared similar experiences and were a similar age as me. But it still wasn't ideal for me, as I felt a lot of fatigue from Zoom and these online meetings. And so later down the line, the friends I had met from the first event and that mutual friend, we all managed to get together locally in Vancouver, and we started meeting at a coffee shop every month. And we called ourselves the Sarcomies, which is a portmanteau of sarcoma and homies. And I hope one day that it becomes a global movement and organization. But what I take away from that is that it's really valuable to have people with shared identities and experiences to know that you're not alone. And I think that over the past couple of days, we've heard a lot of experiences and examples of how we can leverage the healthcare teams and system to connect patients, especially newly diagnosed patients, sarcoma patients, rare cancer patients, to other people that have similar experiences. And some examples are the phone support line that Sarcoma UK has, and how they have direct referrals once you get diagnosed. There's different organizations where these peer support and advocacy organizations are connected with the healthcare system. And I think we need to continue this on a global level. And so I hope everyone in this room that's affected by sarcoma knows they're not alone, and knows that we all are here to support each other. And my call to action is that we have a duty for all sarcoma patients to feel supported and to know that they're not alone. And the reason for that is because these connections that I've had have gave my life a high quality when I was at a low. Thank you.
Thank you, Matt. I didn't expect when I was asked to speak about AYA experiences that I would have to dig back to 7 years ago. And you give me hope for my sarcoma survivor. So I'm Lennie Woods. I'm mom to 2 AYA cancer patients, both diagnosed at 17 years old. This will help me. I'd like to start with a video that it's just a 1-minute video that we made for another talk to kind of show, it puts a face on it. It's a video of scanxiety. Everybody knows what scanxiety is. That's one thing we all talk about, adult and AYA. And this is just a little video about it with my 2 girls, and I think it'll help. So thank you.
Me saying what?
How do you feel right now?
I'm irritated at everyone in this room.
Why me?
Why me?
Why me?
That's Jackie.
Why me? Who's whiny?
Am I slouching right now?
Yes.
Not too bad. Jackie, how are you feeling right now?
Oh, my back kind of hurts.
Jenny, how are you feeling?
Nervous.
Sarah, how are you feeling?
Tired.
Tired? Does everybody need a nap? Dr. Dixon just popped his head in.
30 seconds later.
30 seconds later, after Dr. Dixon popped his head in to say, scan looks good. How do you feel now?
Doing good.
How do you feel, Sarah?
I had a good feeling about it.
Less irritated.
I had like a psychic feeling that it
That
was
all
gonna
was
be
gonna be
nothing.
good. Isn't it
Still
funny?
nervous. Still nerve-wracking.
Right. Isn't it funny though how
Yeah.
this is what we call scanxiety?
I thought it was pronounced skanxiety.
So we've had some of our patients, actually, I saw one recently, they do those little TikTok dances in the room. I mean, we go twice a year, and when I had 2 girls, just seemed like we were always doing that. So that's a little bit of what life was like. But as my girls started to get farther out from their cancer, you see I had one with sarcoma who did not have to have any treatment. And then I had one who was diagnosed with Hodgkin lymphoma, who went through she had a treatment and went through 6 months of chemo. It was really hard. I think an AYA experience, I'm learning from this event and from hearing from both of you, I think that I have a lot of PTSD too. But, and I think becoming an advocate, and those out here who know me and have talked to me know, I don't really think much about their AYA. It was tough. Some of the things that Matt talked about, my girls had, but also as a mother, Sarah had a top state scholarship and had it ripped from her when she had a recurrence because cancer is not a disability. So we appealed it, we lost, we appealed it again with a lawyer, we got a partial back, but it was like she was punished for her cancer coming back. Those kind of things really were hard to deal with. We had applied, right before her diagnosis, we had applied for life insurance. I thought I'm gonna get my kids started out in life. And then the diagnosis came, so she's uninsurable. So there's all these things that AYAs have to deal with outside of fighting the cancer. My husband and I used to say all the time, man, the fighting cancer is not really fighting cancer. It's fighting insurance. It's fighting the school system. It's fighting to keep a scholarship. So, I'm sure you all have heard some stories. I've got plenty. I'm happy to talk about them. But I just wanted to, so Sarah was diagnosed, and then 18 months later, another tumor grew back, her sarcoma, clear cell sarcoma. And then right after that, we kept telling the doctor, both my girls were athletes, varsity athletes. We kept telling the doctor something Jackie wasn't feeling good, and they were like, no way both your kids have cancer. Well, they did in the same year. So the last picture, I'll end with the last picture. I only have one picture like this. We don't have many. I just didn't want to remember it. It felt weird. It was a weird time in our life. But one positive I can say, and this sucks, but I think it hurt Sarah a lot when Jackie got diagnosed, but they were really there for each other. They didn't have, like what Matt talked about, and finding your people. Unfortunately, my girls had to find each other as their people. Jackie, right now, she's getting married 2 weeks from yesterday, so I've got to get home and get to a wedding. But Sarah is still struggling a little bit, being that they were 17, like what you said, it's a weird, critical age. She's still trying to find the job. I'm trying to tell her it's okay. They're both in different phases, but they're both doing well, and they know this work I do, and they pop up and contribute sometimes, do fundraisers. So any questions for any of us, we're happy to answer. Do we need a microphone?
Thank you all so much for this. I don't know if I need a microphone. Kind of loud noise of this. But thank you so much for this. As an AYA myself, diagnosed at 30, the conversation, you're too young, or I hear that a lot from people in the community that they heard throughout their diagnosis journey, you're too young. So thank you for contributing to changing the narrative for a cancer that clearly impacts a younger demographic. My question is actually for Brian. In the NCCN quality care guidelines, hello, sorry, there's a big pole in the way. Is there data on how often they're readdressing these conversations of quality care? Because I know, especially with fertility, that's actually a conversation that is happening more often now. It didn't always. But what I hear from we at Sarcoma Foundation of America do also have an AYA committee where we discuss these things and how we can advocate for better care. What they're saying is, we hear about it once, maybe, and then it doesn't get readdressed. And because AYAs are in a population of people who are going through transitions consistently, how often are the quality care conversations being readdressed throughout their care for sarcoma?
That's a fantastic question. And so that one particular study was just one moment in time. So that was just kind of like a simple, I think to try to maybe illustrate the point that you're making to some extent too, mention like documenting it once and saying that you feel like it's covered, like that doesn't feel good. And I think that part of the, and this is, again, I didn't focus on this here, but that the idea behind these conversations identified as being critical. I think what the real call from the NCCN is that there should be programs, that there should be dedicated AYA programs, so that you have people who feel comfortable talking about all these different things, right? Because that's another thing that I didn't mention here, but there, especially in kind of pediatric silos, right? Fertility is not often something, as a former pediatric oncology fellow myself, my education in giving fertility counseling was like pretty limited. And I actually think I had people at my institution that were good at it. But like how it actually trickled down to me as a primary oncology provider wasn't super effective. And there was one person who I don't think she's here today. She's now at the NIH, but she was a social worker when I was at Hopkins, which is where I did my oncology fellowship. And it was basically like, where's Devin? We got to talk to Devin, because Devin will come and she will help. And she knows what to do. She knows how to, like, the logistics of fertility preservation for each different age range, like where we're going to partner in the community with fertility preservation, particularly if there's like a financial concern. There's a lot of steps that go into it. It's a really critical thing to talk about. And as with a lot of these issues, like provider discomfort, like shouldn't be the thing that like dictates what happens, right? And I think that's true for fertility, it's true for genetic counseling, it's true for clinical trials access. Just because we don't have the sufficient knowledge like ourselves to give doesn't mean that we shouldn't be working really hard to be sure that we create a system that gives that to people. So it's a really, really great question and kind of hits the nail on, I think, what the point of that NCCN initiative is to say, like, we need to do a good job of making this consistent.
Can I ask a question? So in our experience, when Sarah was first diagnosed, there was some question about whether she was metastatic at diagnosis. In fact, it ended up being infection, but there were dozens of spots in her scans that they favored for metastases, and that scared the doctors, and they wanted to immediately start the Ewing's protocol for her clear cell sarcoma. I don't even know that we had the full testing back yet. My husband and I, of course, she's 17. We haven't even told her all of this. They're showing us outside the door. She had lived at the hospital for a month. My husband and I felt, and you got to know Kelly, who is our scientific director, is also a best friend, and she was pouring through publications and really saw the evidence that was published that chemotherapy was at best just not helpful. And so we said, no, but there was a lot of pressure and I know you didn't talk much about it, but that you do focus some on palliative care. And we just wanted to take her home and give her the best life that she could have if, in fact, she was metastatic. And so we really felt pressure to not have those thoughts. When she had the recurrence, we were down at MD Anderson with a different doctor. And right away, when they thought they saw something, she had to have a biopsy. Our first thoughts were, don't pressure us. We told the surgeon had a different view, Dr. Andrea Hayes Jordan, and she said, I would never do that. But we had to say that up front because the pressure comes so great, and you've got your 17-year-old who's looking at the doctor going, well, if they think I should do the chemo, I should do the chemo, and parents still of a minor child saying, if it's not going to work, why do we want to do this to you for 6 months or whatever? So what are your thoughts on that?
Yeah, no, and that's another really great question, and yeah, not definitely not what I talked about here, but I do think that a really kind of critical aspect with, definitely in my mind, just because of my training, kind of cancer in general, but particular sarcomas that oftentimes are really hard to treat, is that I think that there should be a stronger kind of across the board, I think, education of providers to really bridge the gap that exists between the conversations that we sometimes have before we go to talk to families, or the conversations that we sometimes have in our tumor boards about what this disease is, how hard it is to treat, what the survival ratios are, all these kinds of things, because we have that information, and how we actually then communicate that to families. And that's a really hard, challenging thing, because oftentimes you're having these conversations with families who maybe are just learning about what they have, maybe are just learning about a scan that didn't go well, right? So you have to contextualize how are you going to give that information in as empathic and hopeful but honest way as you can. Because when we ask people, they usually tell us too that they want honesty, right? And all this to say, this is kind of rambling a little bit, but there are, I know a lot of St. Jude just because of my own research interest, there are people who are really, really interested in the idea of improving communication kind of throughout the cancer journey for specifically pediatric and AYA patients that are asking these exact same questions, how do we do that better? Mm-hmm. How do we navigate this better with families? And these are studies that I think should be really widely advertised and discussed and taught at the kind of younger level to make sure that those experiences don't happen as often as they are.
It's unnatural, I think, and I get that you want to do everything you can, but in sarcomas with so many who don't have treatments, it needs to be part of the conversation.
Right, and or just the goals and values and the things that that you care about the most should be the things that we are really trying to focus on. And it could very well be that even with kind of all the information and knowing the odds, right, that the decision is made to go with that really aggressive therapy. But with all that information is a really crucial part of it. And if it's just being treated as, oh, this is what we do for this cancer, and leaving you and your really wonderful friends to kind of find that out online, what the actual evidence is, that's not good. Right. That's not how it should be.
Thank you. Thank you.
Yeah.
Hey, Kurt Weiss, Pittsburgh. Brian, not so much a question as a request for you and everyone on the panel. I got a few more gray hairs than you, and when I went to my first CTOS about 15 years ago, there was no discussion about AYA. There was pediatric and adult. There was bone and soft tissue, and that's it, and that's all. It's not that way anymore, and that didn't happen by itself. That happened because people like you three saying, no, this is important and we need to do better, and here's why. So I guess my request for you and for really everyone, and hopefully that diffuses to everyone in the room, is keep your foot on the gas, man. This stuff is important, and it's really, really valuable, and thank you, and hopefully we can do a better job for you moving forward.
That's awesome.
We're going to make that a movement. But my question question for you is in the adolescent young adult committee that we have at SFA, and not just from the committee, but from the entire community, isolation is a huge conversation and ways to solve for that isolation. However, on the flip side of that, AYAs are also sometimes nervous to join a support group for fear of what else they might hear or see or might not ready to be introduced to, be it somebody else's outcome or an overload of information. So I'm curious about your perspective as someone who has made strong connections, what you would recommend to an adolescent young adult who is isolated and wants to make those connections but doesn't want to do it by way of support group. And I know that there are so many amazing organizations out there where they can connect, but sarcoma specific can be hard to find, which makes it even more isolating. So I'm curious what you would recommend for someone who does want to connect.
Yeah, it's a great question, and thank you for it. I think one of my other hats that I have is as a researcher, and I work in men's health research. I do qualitative data, and I actually been doing a project on peer support, and I've volunteered as a peer support worker in the past. So I have a lot of experience in the area, and I think the most important piece with peer support is that we're here to listen. And it's really important that when you are supporting other cancer patients or people affected by cancer, that your job in that moment is to listen and to be empathetic. And I think when that happens in these groups, it can be really powerful. And maybe what we need is then people or these guides to how can we mentor each other and be leaders or advocates of groups and show people the power of listening and being there for each other. And so I know there's lots of groups, and maybe it's online groups or Facebook groups where it can get about advice or medical knowledge, and there's a lot of conflicting information, and that can really taint the image or the experience of people in these groups. But it's really important to go back to that core, that just being there for someone and listening to their experiences and meeting them where they're at. Maybe they don't want to hear about research and all the treatment options. Maybe they don't want to hear about probabilities and survival ratios. Maybe they just want to rant about how they have pain and discomfort. Maybe they just want to rant about how, life doesn't look like how they expected it to be. They wanted to go to school, they wanted to do this program, but it was on hold, or they had friends that left them because they were out of school for years. And so I know I'm not touching on the alternative ways that we can find support as sarcoma patients, as cancer patients, but I think that for all of us to understand that these conversations, and it's the little things that really bring a lot of impact and understanding to each other. Thanks.
Is that it? Are we? Any more questions? Nope. Well, thank you all for a great conference. Really, and thank you for staying.
Give me those chocolates down there. Thank you.
So, unfortunately, this conference has come to an end. A little bit earlier than expected. So, I think we have seen fantastic days, 3 full days of really meaningful meetings, but also inspiring presentations and also very, very good discussions. And as just we have heard, very, very good examples or personal stories that really make a difference. So thank you very much for this. And we came together here with 130 participants from all over the world. And this really showed us that this is a really great and really powerful community as we are as a global sarcoma patient community. And for the very first time, we have had the great opportunity and the pleasure to run this conference here in the US, outside Europe. And this also in a very close partnership with the NCI. I think that's also very, very important. So this has showed also that we have seen a lot of spirit, a common spirit of collaboration and working here together within this community, but also this brought our engagement together as a community, but also together with our medical colleagues, with the researchers now to a next level. So I think this is also very, very important what we have seen. And so from really the bottom of our hearts, we really want to thank our colleagues from the NCI really for this great opportunity really in working together and running this conference together. During these days, we have seen different formats. So we have had medical sessions, but we also have shared our best practice. We have seen wonderful projects today with our Advocacy in Action Award, but also educational session that really brought us more information in the direction of understanding the diseases much better in the field of research, but also in the field of care. So we also have seen a lot of communication also in the direction that things are bringing us forward. And remember our first discussion we have had on the first day with our colleagues from the researching community and the medical community. They count on us. They need us. So we need this relationship in moving things and driving things forward. So I think this is a strong partnership for the next years, but also on a national level, but also on an international level. So as we also try to explain a little bit, and I think many of you has experienced this during the last years now that SPAGN has grown into a really strong global community, bringing together the different stakeholders and working together to improve the lives of the sarcoma patients worldwide. And really, there's a lot of power and a lot of impact, and there are a lot of opportunities with this community. We also have seen during the last day very truly a moving moment when we have had the opportunity really to honor some of our colleagues with our Lifetime Achievement Awards. So with Widemann, Jonathan and Estelle and also Norman. So this was really a great moment. And these are some of the examples, and I think we have really a lot of people in the room, maybe everyone in the room in the meantime, who is doing such a brilliant work in bringing a contribution really to the lives of our patients. That means to change the lives of our patients, the individual lives on a day-to-day basis, but also, as we already discussed, the lives of many sarcoma patients by doing your advocacy work on a national level, but also on an international level. So we want to thank you all, because some of you have really traveled half the way around the globe, and you gave your time and your energy and your efforts in coming to this conference. And also, I think that's important. We can do a lot of presentations. We can create a wonderful program, but this conference really, the main part of the conference are you, because you are the participants of the conference with all your discussions, your networking, and your interaction with one another. And I think a lot of people have been really in favor to meet old friends during the conference, but also make new friends during this conference. So this is really a fantastic community and a great way forward. And I think this connection, what we created over the last 15 years and what we try also to live every day beside our national work and beside our normal work, I think this drives us forward and really unites us in our, what we called our motto in working together and making a difference. So thank you very much for this. So we want also to thank our colleagues from the industry for their really strong commitment in supporting us over many, many years with supporting partnerships, but also with the direct project funding. I think we can have a great history now in working together with the industry during the last 15 years. We made a lot of progress together. Sometimes we move forward in a very constructive and a very united way, but sometimes it's also on you to get some criticism also from us, from the patient community. I think that's important, that we have a lot of interaction and a lot of, I would say, unity in some of the things, but we also are patient representatives. And so it's very important also to come with our problems, with our challenges, but also with our criticism to the companies and really discuss this in an open way. And we are very grateful that this is possible with all the companies. So, and with this, I would like to hand over to my lovely colleague.
Thank you. Well, as one of the US-based members of the board of directors of SPAGN, I have had the opportunity to be really involved in the planning of this meeting, and it's just been such a great pleasure to actually see it come to fruition. It was a year in coming together, and it has been, as many of you know, a very challenging year. So I really want to extend some very special thank yous to our colleagues at the NCI. As we had noted, Dr. Brigitte Widemann from the Pediatric Oncology Branch has been instrumental in planning and has been just with us all the way, multiple phone calls, and it was just profoundly disappointing when she was unable to be here in person. But I want you to know that she was on the Zoom, and she'd love to be a participant, at least even though it was at a distance, and she's truly committed to joining us at our next meeting next year. And so I hope that we will all have an opportunity for you to meet her. She's fabulous. And Trish Whitcomb, who's been a terrific support to Dr. Widemann and to all of us as we plan this program, has been very instrumental. And Dr. John Glad, who really stepped in and helped take many of the presentations that Dr. Widemann had intended to do, and we really appreciate and know that we could not do this without your help. So we're very, very grateful. Excuse me. And again, a conference, where would we be without all of our speakers, our panelists, our session chairs? They really, the time and effort put into this really has led to this successful conference. And what a lovely dinner last evening, and many thanks to Brandy Felsler and her team at Sarcoma Foundation of America for sponsoring that dinner. It was lovely. It's nice to sit and talk and think and really opine on some of the challenges we face. And then it's just really so nice to share a meal together and an evening together. So it was lovely. Thank you for giving us that opportunity. I also want to be sure to, I'm just standing here on behalf and on the shoulders of a wonderful team of the SPAGN board, and they have, each and every one of them has supported this program and had input into it. So I thank my colleagues for all of their efforts, and certainly the incredible team and staff at the SPAGN office, Catherine, Miki, Corey, and Ivana, who's not here. Thank you. And then lastly but not least, to all of you who participated. It's been just wonderful to see your engagement, to learn from you, and for you to share your insights and sometimes be a little provocative and ask good questions. So I hope that each and every one of you will take home something that will help you in your role as a patient advocate personally, for your organization, and I know that it's going to make us better as a strong global community. So thank you for being here. Safe travels home, and we look forward to gathering again. And we don't know where it's going to be. So if that's going to be your next question, we're just trying to get through this one, and we certainly will address that. But thank you for being here. Oh, somewhere in Europe. Ooh, hot off the press. Thank you. Thank you.